Hello, my name is Faraz Musa. I'm a vascular surgeon at the University of Texas in Houston, and I'm one of the principal investigator for the Improve AD trial, which is a randomized trial on uncomplicated Type B aortic dissection based in the United States. Thank you for the BJS Foundation for the opportunity to present our work. These are my disclosures, and before we get into the details of a randomized trial, the basic ingredient to that we need to fulfill in order to perform a trial. The UG3 UH3 is a mechanism used by the National Institute of Health, and the ingredient across countries and continents is the same. You gotta have to show equipoise, which means a balance between the forces of interest of different group of people who treat the disease. So you can have 50-50 in ideal circumstance, or 60-40, or even 70-30. They cannot all agree and all disagree, otherwise you will not have a trial. So the balance of forces or the interest is key ingredient in order to proceed with a randomized trial. And why do we need a trial on uncomplicated Type B aortic dissection? You gotta have to just simply look at the evidence. We have two small randomized trial. This is the graph of the INSTEAD and the INSTEAD XL, which was published in 2013. And that did show that early stenting is safe, remodeling is good, with the INSTEAD XL and also with the adsorb trial, as you can see. And there's a potentially for a late mortality benefit, or the mortality may be improved. And there has been a small and systematic review that showed a odds ratio of late aortic related mortality is almost three times higher with basic with best medical therapy. So there is small amount of data that shows that uncomplicated Type B dissection could be treated with TEVAR. Unsure the benefit is big, if any, and the mortality benefit is small, but there is a signal. So it's really not definitive in any way to commit somebody to the treatment. And that is back to the question of equipoise. Between 2013 and 2020, there has not been much in terms of data increase or influx of data. However, we did have in 2020 the reporting standard from the Society of Vascular Surgeons and the Society of Thoracic Surgery, which introduced the high-risk features, which were then adopted in the AHA and the American College of Cardiology guideline, and gave a TEVAR a 2B. And interestingly, the European societies actually adopted even a more aggressive stance on TEVAR, with giving it 2A from the European Society of Cardiology, without really not much data between, as I said, between 2013 and now 2023. In 10 years, there has not been, definitely not a randomized trial. And all the case series are small and retrospective with no proper follow-up or adjudication or core lab. So that really led to the current effort that we are undertaking, and also the other trials in Europe that is currently underway. And for our trial and the other trials is really the $10 million question is or many $10 million questions about timing. What do you do with the left subclavian? How about cost effectiveness? And how many of those patients do form an aneurysm? And how about genetics? How about the collection of images and what is the goal of medical therapy and the class of medications, and what do the patients want, and surrogate endpoints, and are these high-risk features, could these high-risk features be validated? So the trial design of the Improve AD is as such. It's funded by the National Heart, Lung, and Blood Institute in the United States, out of three main institutions, UT, Duke, and SUNY Downstate, and it's structured in such a way that you have a clinical and a data coordinating center and an executive committee and a whole host of other committees in 60 sites in the US and soon to be Canada and a few sites in Europe. The hypothesis is straight and simple. For patients with uncomplicated Type B aortic dissection, is upfront TEVAR superior to the current standard of care of medical therapy with TEVAR and or open repair when needed? The trial is designed in such a way that patients present between 48 hours, 6 weeks, with inclusion-exclusion criteria met. They get randomized 1-to-1. We're going to collect 1,100 patients with remote follow-up and primary endpoint of all-cause mortality, major aortic complication at 4 years. There's a host of secondary endpoints that are important. Just to dig a little bit deeper into the primary endpoint is a mortality, as I mentioned, and whenever you select mortality, you have to select equally devastating complication like rupture and visceral malperfusion, clinically proven, and as well as imaging and laboratory, retrograde dissection, need for dialysis, tracheostomy, and need for open thoracoabdominal repair or a branched or fenestrated endovascular repair. So really host of terrible complications when they happen, and this will constitute the primary endpoint. The inclusion is wide. We did include Zone 1 TEVAR is allowed. Zone 0, we excluded those patients. And in terms of exclusion, again, it's pretty pragmatic trial in that exclusion is the standard, if you will. Proposed ancillary endpoint studies and quality of life, genetics, and imaging. And where are we currently in terms of enrollment? We are actually at 126 and not 121 with across 50 sites. We are expanding into 2 Canadian, hopefully 4 Canadian sites in 3 new US sites to a total of 60. So we're very excited. We're slightly behind in that in enrollment, but that is not unexpected. We're making the corrective measures that are needed, and the NIH is part of those corrective action plan. And I want to highlight that there are 2 other trials that are Ernest and Sunday, Ernest in the UK and Sunday in Scandinavia and Australia and New Zealand, part of Europe. Both are smaller, however, are equally important in terms of broadly. We could say that the trials are trying to achieve a similar outcome or similar endpoint in one way or the other. We should be able to work together to achieve a coherent merger, if you will, of the 3 trial upon completion. So I'm going to leave you with this quick case presentation of a 68-year-old woman who presented with chest pain and heaviness. And if I can play that CT scan, you will see that she has the classic uncomplicated Type B dissection where the visceral vessels all come from the true lumen, celiac SMA to renals, and the SMA has a little bit of a dissection goes into it. So I'm going to show you that again. And here's a celiac. Here's the SMA with a little bit of a dissection, but no malperfusion, 2 renals, and then the end of the dissection right there, just below zone 6. Or patient has a history of hypertension and a dilated ascending aorta. She was treated for hypertension and went home with no complication, and she continues to be maintained on blood pressure medication. So the question I'm going to leave you all with after this presentation is there ever a reason for TEVAR in patient with uncomplicated Type B aortic dissection outside of randomized controlled trial? I hope after my presentation the answer would be no. Even with high-risk features, you would consider those patients to be candidate for the closest trial to you, which is Improve, Earnest, um, or Sunday, and consider all patients to be approached for the trial. And the conversion rate is 1 in 4. Depends on your persuasion, but it's generally 25% for a trial. So it's lots of hard work, and we need everybody to do their part by enrolling their patient. Thank you again for the opportunity, and hope happy trials.